morning, everyone. So I'm going to be talking on oligometastatic prostate cancer, and just going to talk through what we know and what evidence there is, and just to see whether we're doing the right thing for this particular subset of patients and what we can do in the future to make things better for them. The objectives of the talk basically is to define oligometastasis and oligorecurrence, review clinical and clonal patterns of metastasis in prostate cancer, briefly discuss some modalities available for managing local and metastatic sites, and discuss some published reports on the topic. Hopefully it should be a fairly short talk. So the concept of oligometastases was proposed by Hellman and Wichelbaum in 1995, and definitions kind of have been evolving, but the current accepted definition is a state of metastasis with less than or equal to 5 metastatic sites, and the primary tumor has been untreated. Oligorecurrence, on the other hand, would refer to a state where there's less than or equal to 5 again, but in this situation, the primary tumor has been treated. There are other concepts related to these conditions. So you have induced oligometastases, which is a situation where a patient has widespread mets, and after systemic therapy, most of them are eradicated, but just a few are left. Oligoprogression, sort of the opposite, where patient is controlled largely by systemic therapy, but a few foci of metastases are progressing. So why is this sort of clinical state of oligometastasis becoming a sort of dilemma? Obviously, in the PSA era, with PSA monitoring, people are being diagnosed earlier. So in the past, over a quarter of patients were diagnosed straight on with full metastases, but now it's reducing and reducing and reducing. So people with, sort of the PSAs above 10 tend to have a bone scan, and if there's any metastases, it's seen quite early. It's more regular imaging, new imaging modalities being used in the diagnostic process, including MRI, PET scanning. It's reduced morbidity from local therapy, so surgical techniques have gotten better and better. Radiotherapy techniques have gotten better and better. And in the past, the whole dogma about not treating the local site was because of all the morbidity associated, and you wanted to spare the patient that morbidity if you're not going to cure them. But with the reduced morbidity, then people are starting to reconsider the advantages of actually treating the local site. There's also an increased availability of therapeutic modalities for metastases, which we'll talk about briefly, and also the availability of systemic therapy that's becoming more and more life-prolonging in this setting. So just quickly going through the TNM staging of prostate cancer, focusing on the metastases at the bottom. So M1 can be subdivided into M1A, which will be non-regional lymph nodes, M1B to be to bones, and M1C to any other site with or without bone disease. So as it is now, we're lumping everybody in M1 together and treating them as if they're the same. So we're going to try and see whether these patients are truly the same and whether we should be treating them the same. We'll go quickly through some of the theories of metastases. Looking historically, Paget in 1889 first came up with the seed and soil theory, basically proposing that metastasis is not a random act, so cells from particular sites tend to home to particular distant metastatic sites because of a favorable environment in the distant site. Halsted in 1894 proposed his theory, which is sort of the opposite, saying that metastasis was like a staging, anatomically staging progressive process. And Ewing in 1929 came up with his own theory, which basically, probably it's a little bit of a mix between the two, saying that metastasis occurs at sites as predicted by the blood and lymphatic flow. And I think reality is somehow or somewhere a mix of all these different theories, because we do see these different aspects manifesting. And the question also then is that, do particular kinds of malignant cells adapt different types of seeding methods? So are there particular kind of malignant cell that would go through a seed and soil kind of theory straight to bone? Are there a particular kind of cell that will go to lung or some other metastatic site? There are several sort of pathological studies done in the past, but this particular one is one I've sort of looked at to see what it can show us about how prostate cancer metastasizes. So this is an autopsy study of a large number of men, but 1,500 of them had prostate cancer. Amongst them, 35% had metastatic disease, and 90% of them had bone mets, 46% lungs, 25% liver, 21% pleura, 13% to the adrenal. So that again shows us the predilection, which we know clinically, prostate cancer likes to home to the bones. They also found that the frequency of spine mets was inversely correlated with lung mets. So the patients who had spine mets typically didn't have lung mets, and vice versa. And also they found that patients with spine mets typically had smaller primary tumors, which again would suggest that metastasis happened earlier to the spine than to the lungs. There's also a decreasing frequency of metastases from going from inferior to superior along the spine, showing that in keeping with Ewing's theory, that probably blood flow going through the lumbar veins is sort of helping to seed metastases through the spine. Looking at the molecular level, there have been studies that have shown that cells from metastatic sites could be sort of traced back to their origin in the prostate. So that tells us for sure that not every cell metastasizes, not every cell has the capacity to metastasize. And when those cells start to metastasize, they then form colonies in the distant sites. This particular study looked at 30 men and sort of traced the origins of their various metastatic disease. And basically they could find the particular prostate tumors where these metastases had come from. So this tells us that the prostate continues to be active in the metastatic process, so it's not just a one-time event, it carries on happening. Looking also at what we know about circulating tumor cells in prostate cancer, we know that men who have higher number of circulating tumor cells have worse prognosis. This particular study looked at 231 men and found worse prognosis and worse survival in the men who had greater than 5 CTCs per 7 mils. They didn't really mention the status of the local site, so we're not sure whether these people have had their prostates treated or not. I suspect it's a mixed bag of people who are relapsing after treatment and people who were diagnosed with metastatic disease. The point here being that circulating tumor cells or the burden of cells in the bloodstream correlates with your prognosis. It's also known as well, I'm not showing the data here, but that circulating tumor cells could then come back and recolonize the prostate. So the prostate remains active in the process of progression and metastases throughout the patient's disease. So the question as clinicians we have then is, you have 2 men, similar age, no symptoms, one with a higher PSA and much higher burden of metastases. And the question is, are these 2 patients the same? Should we be treating them the same, or should we be doing something different for one set than the other? And current data that we have is starting to show us that we should be treating them differently. This is data from the STAMPEDE trial. So this is just looking at the control arm. So these are the men who were treated with ADT alone. This was published last year. I think some more data is coming out either later this year or next year with complete study results. But this is just looking at the control arm. So these are men who had only ADT. So it's 917 men. And basically, the point I want to make, or I want to get from this particular slide, is that men who have different types of metastases or metastatic sites have different prognosis. So if you have bone mets, looks like you have a worse prognosis than if you had soft tissue mets, or a combination. If you had a combination, then your prognosis was even worse. This again tells us that all these men with metastatic disease are not exactly the same.
Yep. The definition of soft tissue then is lymph nodes.
So yeah. Any soft tissue. Yeah. So in the Charter trial, which I'm just going to briefly mention, they found that people with visceral mets had a worse prognosis. So these guys here haven't really differentiated, lymph node from viscera. I think that's an important distinction, because lymph node mets will probably have better prognosis than visceral mets, liver.
You would expect visceral mets to have worse prognosis.
Yes. So again, looking at this is the Charted now trial, and this again just to show that all these men with metastatic disease are not the same. So the Charted trial showed convincingly that men with high volume metastatic disease benefited from extra treatment with docetaxel, apart, in addition to ADT, versus men who had low volume disease. So men with low volume disease didn't benefit from that additional treatment. So it says that their disease is not really the same. And they defined visceral mets, they defined high volume disease as greater than or equal to 4 bone mets, which is kind of similar to the definition of oligometastases. And looking back, sort of just more than 10 years ago, this was sort of predicted already, because a group in Japan had already sort of looked at a small group of men, so 56 men, who had bone mets, and they sort of devised a way of finding the area, so the area of bone that's affected by metastases, and they'd found way back then that if you have less than 4.6% of your bone surface involved in mets, you had a much better prognosis than if you had more than. So you sort of should have had a hint from way back then that the burden of disease greatly affected your prognosis. And at the molecular level, quite recently as well, they found that certain miRNAs can predict whether or not, you can predict whether a particular sample has come from a metastatic site or an oligometastatic site, or rather patient. So basically an miRNA is a non-coding RNA, and it doesn't really translate into a protein, but what it does is it can modify the translation of other mRNAs into protein. So it basically binds to them and chaperones them off to get degraded without actually being translated. So this particular group has found that certain miRNAs correlated with either patients who had oligometastatic disease and patients who had polymetastatic disease or higher burden disease. They had a different sort of miRNA signature in their tumors. So even at the molecular level, it's showing us that tumors in patients who have oligometastatic disease probably have a different sort of biology. So are there any benefits of local disease control? So we know that reducing the tumor burden and removing a potential source of metastatic seeding will be beneficial from the couple of studies we just looked at earlier on. So we know that that would potentially help with improving prognosis, less circulating tumor cells, less prostate cells in the primary to actually shed further metastases. And also, we know that these men tend to eventually develop some sort of obstructive uropathy. 2005 study of 203 men who were being treated with ADT for metastatic disease over a period of about a median of 21 months showed that about 40% of them developed retention at some point and needed a channel TURP. So from a symptom point of view, there is some advantage or some benefit in treating the local site. So what modalities are there for managing this entity, this oligometastatic disease that we're now talking about? For the local site, obviously there's surgery and radiotherapy, which are sort of the traditional methods. For the bone mets, there's high-dose IMRT and STBR, which is stereotactic body radiotherapy. And for soft tissue metastases as well, STBR, cryotherapy, and surgery, depending on where the metastases are. So do we have any evidence for treating oligometastatic disease in prostate cancer, and what should we be doing? So there's no data from any randomized clinical trials, so we don't have any high-level evidence to guide us. There are some retrospective studies, some case control studies, but typically small numbers, not well powered, and obviously we know all the drawbacks of trying to draw conclusions from retrospective studies. So it's not very good evidence out there of what we should be doing. I'll just go through some of the papers that I thought were probably among the better ones out there that could sort of guide our minds along the direction we should be thinking. So this particular study just describes how they selected out the patients. So this was looking at the CS database, and they basically picked out about 4,000 patients who fitted into the criteria they were looking for, and what they wanted basically were patients who've had the tumor treated, so patients with metastatic disease who'd had the local sites treated, or patients who had not had the local site treated. And as you'd expect, most of them didn't have the local site treated, but quite a few, 47, had prostatectomy, about 100 had radiotherapy, either through conformal radiotherapy or IMRT in 88 patients. And after adjusting statistically and doing all the different statistical checks and analyses, they found that patients who had prostatectomy and IMRT had improved survival, both all-cause mortality and disease-specific mortality. For some reason, conformal radiotherapy didn't have any benefit. I'm not sure if it has to do with the technique they used or whether the dosing was different. Again, this is not a proper randomized trial, so things are not controlled as you wish. Another paper has reviewed different studies that have looked at managing or treating prostate cancer patients with oligometastatic disease. Most of them were just case reports or series of small patients, which, the power is not really enough to draw any firm conclusions. But they came up with 15 studies which they were happy with, basically had at least 15 patients, and all were prostate cancer patients. It wasn't like 2 or 3 prostate cancer patients scattered in a mix of many other patients, and so on. So it's a busy table, but basically just summarizing those papers that they felt they could pull the data together to analyze and come up with some sort of answer as to whether or not there's any benefits to treating the local site and treating metastatic disease as well. And just looking at the modalities that they've used, so MDT stands for metastatic directed therapy. The first half of it is SBRT, and then most of the surgical approaches were lymph node dissections, so dissections of metastatic lymph nodes that were discovered on imaging. And they've pulled the data together, and basically in all the studies that had more than 15 patients that they basically used for analysis, and they found that there was a mean progression-free survival from 50% from all the studies at about 3 years. Whether or not this translates to, how should I say it? I know it doesn't translate to changing practice, because without randomized trials, we can't really come to any firm conclusions. They've also looked at the side effects or toxicity from these treatments, because that's always been the concern of treating patients with metastatic disease. Why do you expose them to all the toxicity if you're not going to cure them? So they've looked at toxicity, and so the top half is radiotherapy toxicity, and the bottom half is surgical toxicity. And basically, the main toxicity will be from bone pain, and I presume that will be patients who the bone mets have been radiated, and also nausea requiring antiemetics, which is not really severe toxicity, in my opinion. And then for surgery, it's mostly lymphoceles, lymph leaks, and so on, and also ileus if they've gone into the retroperitoneum to dissect out nodes. So I think the literature the specialty has realized that there's a big hiatus, because with patients who are having higher burden disease being treated with chemo, hormone therapy, and with all, like I said earlier, all the systemic therapies available and better modalities for treating local disease, we're beginning to realize that we need to look at the benefits or potential benefits of treating patients who have small burden or oligometastatic prostate cancer. There are two randomized studies that are sort of currently underway. One is a phase 2 randomized study that's looking at whether surgery or radiotherapy or just surveillance, which would delay ADT in patients who have small burden metastatic disease. And I think the plan after that will be to decide either between surgery or radiotherapy, depending on the efficacy, which one they're going to use to compare against observation. And the second one is using systemic therapy with ipilimumab, which is an immune modulating drug, in combination with degarelix and prostatectomy, or just ipilimumab and degarelix without prostatectomy, and see again whether having a prostatectomy as part of this combination will or will not affect management.
You're missing the MD Anderson trial that actually we're involved in. So we actually have a trial that's opening up very shortly, but it's already open in the US, looking at patients with oligometastases and being randomized to receive just hormone therapy or treatment of their local disease with either radical radiotherapy or any of those patients.
So we're one of the sites for that.
I mean, I think it's just in the paperwork stage right now. It's almost over.
So in conclusion, there's really no current standard of care for these patients. The guidelines don't really mention them specifically. So the European guidelines, the NCCN guidelines, they don't really talk about patients with low burden disease. They're starting to reflect the results of the CHARTED trial by saying patients with high burden disease should be offered chemotherapy upfront, but nothing is said about the patients with lower burden disease. We know that clinical and translational studies seem to suggest that oligometastatic disease is a distinct clinical entity, and there's low level of evidence supporting benefit of local disease control. and hopefully the clinical trials that are in progress in a few years' time will be able to give us some information as to whether treating the local site and the sites of metastases in oligometastatic patients will be of benefit. Thank you.